so myelofibrosis is rare. There's practitioners who don't see very many patients. There's also patients who are diagnosed with myelofibrosis who don't have enough information or are misguided at times. What do you each see as the major symptoms of myelofibrosis? The patients who come to you, what do they mostly complain about?
Yeah, so it's interesting. Like you mentioned, myelofibrosis is really a disease that can show up or present in many, many different ways. And I certainly see some patients that are completely asymptomatic. Their doctor noticed that they had some abnormalities in their blood counts, or maybe the patient themselves noted that, their abdomen felt a little bit different. And so there's some patients that are really on the spectrum of having not a lot of symptoms, but there are really some patients that have lots and lots of symptoms. And I would say the most common symptom of patients with myelofibrosis is fatigue, which is probably one of the reasons why myelofibrosis and the other MPNs sometimes take a while to get diagnosed. Other symptoms that we see a lot of are itching, night sweats, fevers, and then unintentional weight loss as well.
I would totally agree with all of that, right? I mean, those are symptoms we see. I think, part of the challenge is, are those always communicated in visits with physicians? And, part of that is us asking the right questions, or at least, training our colleagues to ask the right questions, because not everybody is forthcoming about their symptoms, or the alternative is that they get so used to their symptoms that it's sort of the new normal for them. And that is sometimes the tougher part of trying to understand what somebody is really dealing with.
And occasionally there may be some patients that feel like there are certain symptoms that they wouldn't bring up to an oncologist.
Yeah.
And so it's interesting when, I'll meet a patient for the first time and I'm going down my checklist of the MPN symptoms and I'll ask them about itching and they'll be like, how did you know? And so, we're fortunate in the MPN world that we have these forms that have been validated to help us ask patients symptoms that we know are very common in patients with MPN so that we don't miss anything.
So, myelofibrosis is a disease of the bone marrow where you have mutated cells that start to really grow and take over the bone marrow. They cause inflammation, and the inflammation we think causes scarring in the bone marrow. As that happens, the bone marrow starts to kind of contract and not be able to make blood cells. And so blood cells start to go into the liver and the spleen to try to produce blood, and those organs get larger, and that causes symptoms. But all the inflammation that causes the scarring and damage in the bone marrow also causes people have symptoms, and those things include getting fatigued, losing weight unexpectedly, having bone pain and aches. And of course, there's a whole spectrum of symptoms patients can experience, but those are among the most common things. So that's kind of how we think about myelofibrosis. And how we think about, is the disease getting worse? There's things that we look at like blood counts. So if people's blood counts are getting worse, that's a sign of progression of the disease. If their spleens are getting larger, or the livers are getting larger, or they're feeling worse, all of those things, I think, count as the disease progressing.
And, we all know there's been such an explosion in advances in myelofibrosis in recent years, but all of it in the perspective of the recent ASH conference, American Society of Hematology, and their annual meeting, which took place, of course, in December of 2023. So let's start with what's most exciting to each of you. Dr. Hobbs, if you'll start, what came out of that annual meeting that you're most excited about starting again with myelofibrosis?
Yeah, so it's really an exciting conference. I can't remember participating in an ASH conference where there were 2 phase 3 studies presented simultaneously, mind you, about myelofibrosis. And so I thought that in and of itself was really a reflection of how far the field has come, that we're now presenting not just, phase 1 studies on drugs that may never make it to patients, but actual phase 3 studies on drugs that may get approved. And of course, I'm talking about the navitoclax and pelabresib studies.
So, I totally agree with Gaby. I think, when have we had 2 phase 3 studies read out in MF? It's been, I can't remember if that's ever even been the case simultaneously, right? To me, and thinking about this in the context for our patient audience, right? This is a clear sign of progress in the field, right? And let's separate that idea out from, what happens from a regulatory standpoint. Do the drugs get approved? You have to get to this point. This is where the finish line is. And so it is incredibly encouraging, I think, that we've got drugs to this point of phase 3 where we may have, definitive results that could lead to approvals. I think, and what we can probably say, at least with both drugs, is that they clearly have activity in the disease. There's no question, right? What happens from here, of course, is up to the FDA, but I think I'm really encouraged by this. I think these drugs really have the potential to make a difference for patients. So this is really exciting.
Both of these studies were phase 3 studies, like Dr. Rampal mentioned. The navitoclax study was the TRANSFORM study that compared ruxolitinib alone to ruxolitinib and navitoclax. And they wanted to see if the combination of the two drugs was more effective at improving spleen volume response, as well as improving the symptoms of myelofibrosis patients. And they found that the combination really led to a very dramatic improvement in spleen volume reduction in patients treated with the combination compared to patients that were just treated alone. The symptom endpoint was more difficult as it seemed like the combination was similar with navitoclax and ruxolitinib for symptom improvement compared to ruxolitinib alone. And at least my take on that is it's not entirely surprising that a drug that is like navitoclax would not improve the symptoms, but it certainly didn't make patients feel worse. And I think that that's really important when you think about combination therapy as well. So I wouldn't consider that an entirely negative endpoint. And I'll let Dr. Rampal comment on the study he presented.
Let me build off of something that Dr. Hobbs said, right? Which is that, and what you said, Ruth, which is that, symptoms are important to patients, and that has to be part of any of our treatment arsenals. But as you said, we want to get drugs that alter the trajectory of the disease and not are simply focused on symptom reduction. And I think that, going forward as we think about new drugs in the space has to be part of the conversation, right? How much weight do we put on symptom reduction as something that we should, as a community, fixate on, or that the FDA should fixate on? And how much do we say, okay, that's important, but as long as the drug is not making people feel worse, if it's doing other things for patients, then maybe that's really where the win is, if you will. With regards to, pelabresib, this was a study, of combination of pelabresib, which is a BET inhibitor, plus ruxolitinib versus ruxolitinib alone. And the study looked at, did patients have a greater degree of spleen shrinkage? And the answer was unequivocally yes. Patients who got the combination had a much greater spleen response, 65% versus 30%. Why is that important? Why should patients care about how big the spleen is and how much it shrinks? Well, the answer is that is the only thing, or one of the few things we know that actually correlates with survival. We've known this from the time of ruxolitinib, that the more spleen shrinkage somebody gets, it seems that correlates with overall survival, which obviously is something we all care about deeply, right? So I think that is one important thing. With regards to the symptoms, there was at least a trend towards the symptoms getting better with the combination. It wasn't quite statistically significant, but it was certainly a trend that favored the combination. And importantly, getting back to maybe the earlier point, it didn't add toxicity. We didn't really see that there were any new major signs of toxicity with, the two drugs versus one. And in oncology, we worry about that all the time. If you add another drug, you may add toxicity, but that wasn't the case here. So I think, from that standpoint, I'm very encouraged by both data sets.
So, Dr. Rampal, with more options, as we're talking about, more options available both today and the down in the pipeline, in the future, one of the things that I think that comes up often is the question of, especially for higher risk MF, what are we learning about sequencing? What are we learning about optimizing the new drugs and combination drug therapies, including determining when and how to switch therapies?
I think the answer is we don't know. But the broader context of this is that we have more options, right? And so that has two implications. Number one, I think historically there's been perhaps a reluctance to start therapy because you didn't have anything else to go to, i.e. if you were in a world where we only had ruxolitinib, if it stopped working, what were you going to do? That's not true anymore. So I think that part of the big takeaway from all of this, from having all these drugs, is that we shouldn't wait for people to get that sick. We should treat earlier on, right? What is earlier on? There's some ambiguity there, right? But I think that is one of the implications of having a lot of more drugs. The second is, I think the reality is we're going to learn how to use these drugs as we go along. There isn't a great deal of data. Like if I make this a little bit more granular, we have data on switching from ruxolitinib to fedratinib, and we know what happens and how people do when you do that, but do we necessarily have data for all of the other drugs? Or if we start going from momelotinib to ruxolitinib, whatever it is, we don't really have the granular data. Those are things we're going to figure out in practice probably over the next 1 to 2 years, I'd say.
Yeah, for sure. The point that Dr. Rampal made, I think, is so important, and especially when we think about his answer to one of the other questions, which is one of the things we know in myelofibrosis is that a smaller spleen with therapy equals better outcomes. And so certainly an important message for patients is exactly what Dr. Rampal said, which is definitely now that we have 4 JAK inhibitors that are approved, there's absolutely no reason to feel like somebody needs to wait with symptoms from their spleen or their disease, because we really do have a lot of options. And now that we do have a lot of options, it overnight became a situation where all of us were calling each other and asking, how do you switch from this one to the other? Have you had good experience? The clinical trials sometimes don't necessarily translate to what we do in clinical practice. Many clinical trials require that patients be completely off of a JAK inhibitor before they switch to the other, which is something that in practice probably neither of us would ever really feel like doing. And so it is something that probably over the next year we're going to have some publications about that as well to help guide the broader community to do that safely.
So, Dr. Rampal, you mentioned fedratinib. What did we learn about fedratinib at the ASH conference in December?
So the most updated data was the Freedom 2B study, which looked at fedratinib in patients who had been on ruxolitinib, which there were earlier trials. It was the Jakarta 2 trial that looked at the same question. But one of the things that, of course, when fedratinib was being studied early on that was seen was that there was a lot of gastrointestinal toxicity, like a lot of nausea, vomiting, diarrhea, which was experienced by the majority of patients. But there have been 2, subsequent trials, what are called the Freedom trials with fedratinib, where they have aggressively tried to manage these symptoms from the get-go, i.e., we don't wait for people to get sick and have nausea or diarrhea. When we prescribe the drug, we say, when you start the drug, if you start to feel nausea, you're going to take this medication. Or if any diarrhea starts, you're going to take this medication. You don't let these symptoms get out of control. And at least what these data have shown with the Freedom trials is that you can better manage this and that it does get better over time. So is that still a side effect that we have to be concerned about? Yeah, it is. But it is something that in most cases we can manage if we're kind of aggressive about doing that up front. And the expectation is that it will get better over time.
Dr. Hobbs, what about selinexor?
Yeah, selinexor has been interesting as well. This is a newer agent that we've started to see some preliminary results on, and they presented their data also in combination with ruxolitinib. And this agent also seems to have very impressive responses in terms of shrinking the spleen and improving symptoms as well. I think their data are still in earlier stages, and so I think I'm at least waiting to see if this agent is actually well tolerated for patients. And so we'll have to wait and see how the later studies will pan out, but still exciting.
I want to make sure we have time to talk about anemia. There's this unmet need for treatment of anemia for patients with MPN, specifically myelofibrosis, which brings us to momelotinib and also a few others.
So we've mentioned that there are now 4 JAK inhibitors that are approved for the treatment of myelofibrosis. And just to review those, we have pacritinib, ruxolitinib, fedratinib, and most recently momelotinib that was approved at the end of September of this year. And so momelotinib was a JAK inhibitor that was approved a little bit differently than the others. Its main indication is for patients that have myelofibrosis and anemia. Anemia has really been an unmet need in the management of myelofibrosis, and so it's exciting to have a drug like momelotinib that can help anemia, and also a drug like pacritinib that can also help anemia in a subset of patients. And so in my practice, I've noticed for sure since the approval of this agent, there have been many patients that are, especially patients that are active online and here in their communities and in patient advocacy organizations about this agent, or patients that I've been talking to about this drug for some time waiting for its approval that have really been excited or eager to switch to this medication. And so I do think that having this 4th agent will be very helpful in the management of patients with MF, especially those patients that have myelofibrosis, but also anemia that maybe aren't able to get a bone marrow transplant. And so many times when we have patients with myelofibrosis that have anemia, it's important to consider, is a bone marrow transplant the right therapy for those patients? But for those that can't receive that therapy, momelotinib really takes care of a lot of the parts of the disease that we really worry about, both the symptoms and the spleen, but also the low red blood cell numbers.
There is so much going on in anemia in this disease. It's really remarkable. It's really fantastic, right? A problem for which we had no good solutions until very recently. So as you mentioned, momelotinib and pacritinib also seem to have an effect where in at least a proportion of patients, it can increase the hemoglobin, and in some cases take patients who are relying on transfusions and convert them to not needing a transfusion, which is, I think, important in terms of survival. We know that that does correlate with survival, but it's also quality of life, right? If you have a patient who's stuck in the transfusion chair 4 to 6 hours a week or more, and that no longer is an issue, that is immensely important to quality of life. So, of course, it's an important problem. Now, there are some other drugs in development, and that includes a drug called luspatercept, which is FDA approved for a disease called myelodysplastic syndrome. As well, there are some other drugs from a few other companies, one from Disc Medicine, one from Incyte, both that are really anemia-specific drugs, and there was some data presented at ASH on that. So there's early signs of efficacy there. Too early to say anything definitively, but at least it looks like these are drugs that will be studied further.
So, Dr. Hobbs, what do you think is practice changing? So we talk about what's happened in the lab, what's in the drug approval process, what's recently been approved, where our needs still are. What came out of ASH this year that you think is truly practice changing immediately or in the very near future?
So I think to go back to one of our earlier questions, certainly what was very exciting is seeing the 2 phase 3 studies. And so although those 2 drugs, pelabresib and navitoclax, are still not approved, potentially those are closer to our doorstep and something that we will have to have conversations about how to use those. Do we use them in combination with the JAK inhibitor that they were studied with? Do we use them with other JAK inhibitors? How do we think about sequencing when we're talking about combination? So those, I think, are near questions, although it's important to remember that neither of these agents is approved. I think what's been practice changing recently is just having the approval of the last JAK inhibitor that was approved, which is momelotinib. So we now have 4 drugs that we can prescribe to our patients when we see them in clinic, especially those that have anemia.
So the drugs and the studies we've been talking about are all very exciting, but I'd love to know, between the two of you, what else did you hear evidence of, and what other treatments are you excited to share with patients that help you personalize treatment?
Yeah, so I think, we've definitely discussed the Manifest and Transform studies, looking at combination studies in the phase 3, but one of the things to communicate to the patient audience is that truly there are so many drugs that are being evaluated, and it's been very exciting to be at an ASH where we hear about so many different mechanisms of actions that are being, explored. Many of those are by themselves, and some of them are also now getting to the point where they're used in combination. And so just to mention a few, there was a compound called a PIM1 kinase inhibitor, another one that inhibits lysyl oxidase, which is a group of enzymes that have to do with making fibrosis or scarring happen in the bone marrow. We've heard about the LSD1 inhibitor, bomedemstat. There's so many drugs that are kind of coming down the pipeline and really showing really interesting activity, and especially some of those showing activity by themselves, which is something that, generally speaking, when we have new drugs that are not JAK inhibitors by themselves, we rarely see a lot of clinical activity. So I thought that was exciting.
Yeah, absolutely. I think that's a great point, right? I think for our patients, the way to think about this is now there is sort of this whole pipeline of things coming forward, which is amazing, right, for this field. And yes, we spent some time talking about the top line, phase 3, but as Dr. Hobbs is mentioning, there's all of these drugs that are in earlier development that are actually showing us that they may be able to do something. So even beyond what we have, there are things coming, right? I think that's part of the big picture here. Getting into your other question about individualized medicine, I mean, that is sort of the holy grail, right? And there's a lot of different ways to think about it. There's, how we use the drugs we have now, and what some of the newer drugs may be able to do for us. And maybe, a key example of this is calreticulin, right? There's been a focus on this because there are now, in investigation, specific antibodies that target calreticulin. That could be a game changer if those things work. At least preclinically, there's good rationale. But, you could imagine a future where if those drugs are effective, then for calreticulin mutant patients, this is what we do. We have a drug that targets your mutation, right? That is where we want to be. And of course, there's other mutations that occur in the disease, and we've already started trying to do personalized medicine for patients. So there's patients who have what's called an IDH mutation that occurs typically in people with more advanced disease. But we've just completed a trial where we used a JAK inhibitor plus an IDH inhibitor. IDH inhibitors are FDA approved for people with leukemia, and we've combined those drugs and actually seen very good results. So that's kind of an example of genetically informed personalized medicine. But of course, there is how you use the drugs we have in practice too.
So, like we've mentioned a few times, we have 4 different JAK inhibitors, and it's important to know, who are those going to help? Are there certain situations where we should use one JAK inhibitor versus another JAK inhibitor? This ASH, we saw kind of update on a similar study that was published recently by the folks that look at pacritinib, for example, and they found that patients that have a symptom improvement of greater than 10% had an improvement in survival, which is similar to what they showed recently with patients on pacritinib having a survival benefit if they also had a spleen volume reduction. And so, again, that kind of goes to the theme that we were saying, where it's important to use these drugs, make sure that those drugs are actually doing what they're supposed to be doing for the patient, because we have endpoints that help patients not only to live better, but hopefully to live longer. And that can also help the practicing doctor to say, this drug is not meeting those endpoints. It's not helping my patient have an improvement in their spleen or their symptoms. We have other drugs that we should think about switching them to.
Now that we've heard lots of updates out of ASH, as we always do, what can a patient bring to their community hematology oncologist and say, what about this and what about that, as opposed to waiting for it to trickle down? What are some of the ways that a patient can be more proactive with knowing what we now know?
I guess the first thing would be, if you're a patient or a family member of a patient and you're watching this video, you're already taking those steps that are so important. I think it's important to remember that myeloproliferative neoplasms are rare diseases, and so not everybody has access to subspecialized care. And I think what's incredible about the MPN community, first, for you that's watching to know, is that the group of clinicians that treat MPN and are doing research in MPN are extremely committed and passionate about treating these diseases. And we have, we're excited to work with also partners in industry that are similarly very passionate to find new therapies for these diseases. And so that's one message that I think is important for patients to know. And there's lots of great resources online, including this, where as a patient, you can advocate for yourself to recommend different treatments to your provider to make sure that you're getting the most updated care. So I think that's an important message.
Mm-hmm. Yeah, I would say a couple of things. One is that I think, if you're a patient who's being cared for in the community, it's worth asking the question with your physician, when is it time for me to get started on treatment, right? Because again, this is an evolving space, and I think we're more and more being convinced that earlier may be more beneficial, but there is a danger in waiting too long. Second, if you are at the point of needing treatment, it may be worth getting a consultation in a center where there is a lot of experience, because we who are focused on this have the forefront of the developments at our fingertips, whereas the doctors in the community are busy seeing a lot of different types of cancers. They have to keep up on all of this, and they may not have immediate access to that information. So if it is time to get treated, it may be worth a consultation, at least, to say, is this the right thing, or is there a compelling clinical trial that maybe may make more sense, right, in the current era? The last thing is, going back to to paraphrase something you said, we're bringing back hope. We've seen more developments at that ASH than in maybe any prior in the last 10 years that I can think of. That's not unimportant.
Yeah, a very hopeful message. And we seem to say that every year, but maybe now even more than ever. And I think one of the themes that came out of ASH, at least for me, from a patient perspective, is all these new approaches to these old diseases, right? It's not that we've discovered new diseases, it's that these are diseases and patients who have not had solutions for so long, or our options have been so limited, and now there's more and more options.